Welcome to Healthcare by the Numbers, a podcast that uncovers what's driving healthcare transformation. Join us each episode as Caravan Health leaders interview the brightest minds inspiring healthcare innovation and discuss the numbers which have shaped their thinking.
Welcome, everyone. I'm your host, Louise Yinug, Senior Policy Analyst at Caravan Health, and this is Healthcare by the Numbers, a podcast that explores the numbers driving change throughout our industry. To learn more about Caravan Health, this podcast, and to check out episodes of the show, visit www.caravanhealth.com. And be sure to sign up for our newsletter to be notified of future episodes. You can also visit our program page on Healthcare Now Radio and follow us on Twitter, LinkedIn, and Facebook under our username @Caravan Health. Today, we are pleased to be talking with one of our Caravan Health leaders, Nicole Banister, our Senior Vice President of Practice Transformation. Nicole will share her approach to transforming healthcare, lessons learned from working closely with our clients, and what we can expect to see in the future for our clients across the country. Welcome, Nicole.
Louise, thank you for inviting me today to join you. I'm a big fan of the podcast, and I've enjoyed hearing from industry leaders as well as from our clients in season 1 and season 2.
We are really pleased to have you kicking off season 3 with us. At Caravan Health, we've been working on accountable care since the very beginning and have guided our partners in their journey to make the most of practice transformation and population health management. Nicole, you've been a key part of this effort since you've joined Caravan in 2018. For those of you who are not familiar with Nicole and her work, Nicole joined Caravan in 2018 to lead our regional delivery teams in their work with Caravan Health clients on primary care transformation. She and her team guide clients in advanced initiatives such as post-acute care coordination and care management for high-risk patients to get the most out of value-based care. Before her time at Caravan, Nicole spent 5 years designing the learning network for the Comprehensive Primary Care Program as a contractor for the Center for Medicare and Medicaid Innovation. Nicole, anything more you want to tell us about your background?
Sure. I can start by telling you all that I started my career as a dietitian and diabetes educator. From there, I moved into program coordination and then got my master's in healthcare administration and grew into leadership positions with hospitals and physician groups. I spent 15 years in healthcare operations, leading busy practices and hospital departments. And this work really taught me about change management and the prioritization of work, helped me develop my personal passion for patient and family-centered care, and showed me the importance of collaboration and communication with physicians and the entire care team. So for the past 8 years, I've been in coaching and consulting roles dedicated to primary care and value-based care. And 3 years ago, I was drawn to Caravan Health to become part of what is really an innovative startup company that was providing health systems of all types with support in order to be successful in accountable care organizations. And today, our collaborative ACO model, our technology, and our people are making value-based care work for many organizations that had never been able to make the numbers work prior to their engagement with Caravan Health. As Senior Vice President of Practice Transformation, my role is to ensure that every client has the knowledge and support they need to improve the quality and manage the costs of the patients they serve. I manage a team of 20 amazing practice facilitators that work directly with primary care practices. These practice facilitators use data, consider adult learning principles, and a knowledge of their clients' unique situations to drive key ACO programs. We start with foundational programs around prevention and things like an annual wellness visit and leveraging team-based care, and then progress to more advanced programs supporting targeted patients with care management services or improving hierarchical condition category coding or creating improved networks for post-acute care.
Thank you. You're filling in your background much better than I could. So in each of our shows, we like to spotlight and frame our conversation with some of the numbers impacting the industry today. And of course, because we've got a Caravan expert here, we're going to talk a little about some of the outstanding numbers that are connected with Caravan over the past few months. So Caravan's practice transformation approach has helped more than 300 community health systems and more than 500,000 attributed patients in the Medicare Shared Savings Program. In 2020, Caravan's ACOs saved a total of $160 million for Medicare and brought back $68 million of those dollars in shared savings directly to the practices doing the work. Along with those impressive financial results, for 2020, Caravan's ACOs earned quality scores of 97% and near perfect scores in the merit-based incentive payment system, otherwise known as MIPS. And this was all made possible from a dedicated focus on population health and preventive care. And between 2018 and 2021, Caravan clients nearly doubled the rate of chronic care management services from 2.8% to 4.8%. Over the same time period, the rate of advanced care planning increased from 8% to 14%. And this focus on population health services led to a measurable decrease in inpatient admissions and emergency department visits. So those are the numbers. Nicole, you're doing the work, the hands-on work every day of improving healthcare and implementing population health initiatives. What numbers are you most proud of?
There are two numbers, Louise, that I would add to your list that help to describe the depth of our work with clients and the value that clients place on our services. And the first is around our roadmap calls and monthly interaction and support. So by the time we get to the end of this year of 2021, we're projected to have hosted nearly 2,000 monthly roadmap calls with our clients. These roadmap calls are a platform to meet with each client individually to review their goals, provide training, and help identify strategies or remove barriers to achieving their goals in the ACO. These conversations also allow us to remind clients about Caravan Health events and new features or resources available to them on our technology platform, Caravan Coach. Roadmap calls also provide two-way accountability, and I'm proud of the creative ways we've used this time with clients to get the most value for them. So the other number that I would highlight is our most recent Net Promoter Score. Our most recent NPS, as it's sometimes called, was 59. And this score is derived from an annual survey of our clients' leadership team, including CEOs, their ACO champions, physician leaders, and CFOs. And the survey measures loyalty by asking the question, how likely are you to recommend us? And then there's a calculation based on the number of promoters versus detractors to create that single Net Promoter Score. So our score today of 59 has increased over the past 3 years, and we are really now in rare company. For example, the Net Promoter Score for our beloved Apple is 47, and that caffeinated attachment that we have with Starbucks, they have a Net Promoter Score of 77. So our Net Promoter Score of 59 is something I'm really proud of, and I think it speaks highly of the relationship that we have with clients as a trusted advisor.
That's really amazing. Not surprising at all, but really reinforces the value of the work, of course, that your team does, but also that our clients are really our best sort of testimonials to the work that we do. I know we spent some time in the last podcast season talking one-on-one with clients, and it came through in every conversation, the value that they get from the work with Caravan. So I'm curious how your team gets started with new clients. So we work with a lot of practices that are new to value-based payment, these small safety net providers, often in rural areas. I'm wondering, what are the steps you take to get them ready to join an ACO?
Well, every fall, we work with new clients of all different sizes and with different experiences in value-based care work. And our first step is to conduct an assessment to really learn about their organizational structure, key stakeholders, and what their current efforts are around annual wellness visits and coding, care management strategies, and quality reporting. And with this information, we can customize monthly calls during these first few months of support and interaction with them. And a big focus of our early work is often risk adjustment and the ways and strategies that either are in place or maybe not related to hierarchical condition category coding to ensure that the risk adjustment factor that CMS uses to set benchmarks in the ACO is accurate and really provides a clear picture of the complexity and the risk of the patients that are attributed and cared for in the practice. In addition to the individual support that we're providing to our new clients, they also have a chance to participate in group webinars that are highly interactive and really allow them to learn from our Caravan subject matter experts as well as one another. We also share best practices from our legacy clients with new clients. In fact, we just published an ACO playbook with over 50 one-page case studies that highlight examples of really great ACO success across 12 different program areas. And so I thought today you might like to hear some of those examples from our playbook.
Absolutely.
The first one is from Caravan Health in Syracuse, New York. They have 2 medical groups with over 40 locations, and they have an amazing story around their quick shift and ramp up to telehealth work in the spring of 2020. And it supported virtual annual wellness visits as well as acute care visits during the peak of the pandemic. And their 12-month rolling average for AWVs remains incredibly high, close to 75%, really due to their commitment to prevention and wellness using that telehealth platform. Another example is the Hutchinson Clinic that's based in Kansas, and they have 10,000 attributed Medicare beneficiaries that they care for in their clinic. And over the past few years, they've made a really concerted effort to reduce barriers and offer easy access to the influenza vaccine. So they've coordinated their outreach across multiple clinic departments and have even coordinated with employers and their surrounding communities to administer flu vaccine starting in July and August of each year. And so their vaccination rates for flu over the past 2 years have ranged between 77 and 83%. This is really incredible. The national average, according to the CDC, for this population of 65 plus year old Medicare beneficiaries is more in the 70 and 75% range retrospectively over these past 2 years. So they're really above and beyond what we see in typical communities. And that makes a big difference in the health of their population. And then the third example is Bay Clinic, which is a mid-sized fee-for-service clinic in Oregon. And they participate in the Medicare Shared Savings Program, ACO, as well as in the Comprehensive Primary Care Plus program. They have in place a social determinants of health screening tool, along with information about their patients' chronic disease diagnoses. And they take those 2 pieces of information together to identify individuals who could benefit from fresh produce deliveries. And in January of 2021, they started a Veggie RX Farm, FARM-A-C, pharmacy program where eligible patients and their families can pick up boxes of fresh produce at the clinic every Thursday. And in tandem with the produce delivery is some educational materials for the family. And the food is provided by a local food bank. So it's a great collaboration between the practice and the local food bank provider.
I've seen that playbook, and it really does speak to the innovation that's going on among our clients. I will make sure that we include a link to it in the show notes so people who are listening can take a look. It's pretty outstanding. I'm curious what sort of obstacles our clients are finding, like your average community health provider new to ACO work. What sort of obstacles do they have to overcome to get ready to do this value-based payment work?
To me, one of the most common obstacles that I see is adjusting to or optimizing team-based care workflows. At Caravan, we define team-based care as an approach to care delivery that ensures that every member of the care team is working together and with the patient to ensure high quality, coordinated, effective, and efficient care experience. So most practices think they're already leveraging every member of their team and they have great communication and great trust. But what I typically find is that there's almost always some opportunity to improve team-based care through one of 5 principles. Sometimes it's around roles and delegation. Sometimes it's about creating standardized processes. Other times there's an opportunity to change or build trust, to look at communication strategies. And then also the sort of final one is related to training and sharing of expertise. I think one of the best examples of this work, especially when we're working with a new partner, is identifying and then leveraging the dual visit for an annual wellness visit. And so what this looks like, dual visit is our term or word for describing an annual wellness visit that's performed in conjunction with an evaluation and management visit. And this is really, to us, the gold standard of providing annual wellness visits, and it's really the quickest path to success for a successful AWV program. And it could be adding that AWV to an E&M visit that's already scheduled, or it could be by scheduling the annual wellness visit to coincide with some routine follow-up visit. In this example, patients are asked to come in an hour before their scheduled appointment for a visit with the wellness nurse that happens before they see their primary care provider. Dual visits work well because they link what the patient wants, which is often to visit or to see their doctor, and it links it to the annual wellness visit tools that are provided primarily by the care team. And so for a traditional fee-for-service clinic setting, a dual visit also provides the opportunity to bill for 2 distinct visits on the same day for the same patient. And in other clinic settings like rural health clinics, they can't bill for the 2 visits, but dual visits are still really critical for quality patient care. And rural health clinics can optimize their AWV approach by associating the visit with other services like a medication refill or some other type of follow-up. So this dual approach allows sort of most of the AWV to be coordinated and led by a nurse and members of the care team, leaving just a few elements and a quick review of the care plan to the physician. So I think that's a good example of how to best leverage and optimize team-based care, and in this particular example with our annual wellness visits.
Right. And if the clients aren't used to conducting their workflows that way, I can see why that would be a whole challenge that you have to address right up front. I want to shift gears just a little bit because we have, of course, I work in policy, and we've been talking so much this year, in the past few years, about the persistent health disparities in our country based primarily on race and income. And we've seen CMS really approach these things, talk a lot about this, especially in the context of Medicare and quality programs over the past year or so. I'm wondering, and there's been discussion about value-based payment and population health and how that can help improve health equity. I'm curious to hear your thoughts about that, seeing the population health initiatives up close.
Sure. Health disparities are certainly driven by unequal access to primary care. And so we know that before COVID hit, probably 60% of areas designated by the federal government as health professional shortage areas were in rural counties. And so we know that access to primary care is not equal across the country. And that certainly impacts health and health equity. The other thing that I think we saw in particular during COVID was that poor or slow or non-existent internet access in some neighborhoods and rural communities impacted their ability to get telehealth services. And so that was sort of another layer of health disparity or impact to health equity that has come out more recently, or has certainly has had a bigger impact more recently. In our population health work with the ACOs that we partner with, we have tools and programs to improve things like same-day visits or same-day access to a practice. And so if you have a relationship with a primary care practice, having the ability to be seen in the office pretty seamlessly or easily can help to improve overall health outcomes. Another tool that we use in population health is a part of our annual wellness visit called a health risk assessment. This is a really easy to use tool. It's often completed by the patients themselves to help give the care team a better understanding of the patient's overall health, including behavioral risks like tobacco use or alcohol use, nutrition and home safety, as well as psychosocial risks like depression and pain and fatigue. And then very importantly, this health risk assessment can identify social determinants of health, like the ability to pay for medications or current housing situations, social support and isolation, an individual's reading ability and transportation. And so using a health risk assessment template to thoroughly screen for multiple factors that impact overall health is one of the early steps and a great step to take annually to ensure that we're supporting patients' social and economic needs to help to improve their health outcomes. And then working with our partners to establish care management programs that can offer referrals and connections to the community and community agencies to support these needs, because the physician practice is not really equipped to support all of the needs that might be identified in that health risk assessment. So creating relationships and collaborations with the community to support patients' needs that might be best met through another agency or organization. I would also add from a policy perspective, I think that there are a wide array of approaches that CMS can consider for addressing health equity and advanced payment models, like incorporating some element or measure of social determinants of health into a risk adjustment factor. We don't want these alternative payment model participants to be disadvantaged for serving medically or socially complex beneficiaries. And we certainly want everyone to have the resources to be able to continue to provide vital services to their communities. And I think CMS could also consider increasing access to some standardized socio-demographic or social determinant information as part of the data files that we use to help inform our coaching work and our support with practices.
Yeah, I know we included that in our comment letter on the physician fee schedule about how CMS could really be a leader in data collection regarding the demographic factors, and that the first step is getting the information about who you're serving and exactly what the health profile is. And I was so pleased to hear you mention the whole question around telehealth and access to technology, because that's so critical, especially in an era where we really do seem to be making a significant move to telehealth. I know that some of our clients were quite successful actually in getting grants from the Federal Communications Commission to upgrade their broadband services and devices at the beginning of the pandemic. And I think that made a huge difference. We ended up something like 8 of our clients were able to get those funds. And that's wonderful that the government made that available. I do want to just get back to the question about what primary care transformation success looks like. So you have an extensive background in helping providers make value-based payment work. So I'm wondering what your markers of success are for practice transformation. Like, how can you tell when a client is on the right track to succeed and is going to make it?
There are probably 2 things. And one is around the engagement and the enthusiasm with the team and the group of people on site within the client organization that are doing the work. That is probably the first marker of success. And once that is in place, I think we can use data to really drive our work. And Caravan Coach, our new technology platform, has made that work even more streamlined in 2021. And so I can go into Caravan Coach and look at track reports to see trends in key performance indicators around annual wellness visits and chronic care management. And in terms of markers of success, I look at these 2 programs first to help to confirm if most patients are getting the preventative services that they need, as well as a subset of patients with multiple chronic conditions are getting virtual care and between visit care as needed to support their overall quality and overall healthcare experience. We also use Caravan Care reports to help create patient lists to help to focus outreach. So in care, there's an ability to create a cohort or a list of patients that have or might be due for an annual wellness visit in the next month, or that are maybe outliers in terms of their emergency department utilization, or maybe patients who have really a large number of outstanding HCC gaps. And so having a team that's trained and ready to support targeted patient outreach is really a marker of success in the ACO.
You mentioned staff engagement sort of as the first step, which seems to me really a fundamental building block of making sure that the whole team is on board with value-based payment. I imagine those roadmap calls that you mentioned earlier are a real sort of anchor for making sure that communication stays open and that you've got the right people talking about doing the work.
Yeah, those roadmap calls are really important for engaging all different types of roles within the organization to support the work. And it's usually a red flag for us when we have those calls and it's only one person who comes, and it sounds like or seems like it's only one person who's trying to do the work in the clinic. And so using the roadmap calls and incorporating and involving a lot of different individuals, people that have different perspectives and different responsibilities and leverage within the organization is an important part of being successful in the ACO over the long term.
It sounds like a great system. All right. So I'm curious because, of course, I work in policy. Like I said, you've worked closely with CMS and CMMI in your work before Caravan. I'm wondering what the most important steps you think that those government agencies can take to further the movement to value-based healthcare.
To me, in my experience, especially in primary care, there are two areas that I would call out. And one is providing upfront investments to model participants. And the other is technical support, including coaching or the creation of learning networks. And I say that, or I think of those two examples because we have made much progress in this movement to value-based care. But still, maybe only 41% of the Medicare fee-for-service payments flowed through an advanced APM in 2018. So there still is a lot of opportunity. So we should think about those strategies or areas where we can include more providers and expand that value-based care work. Really providing more technical support to alternative payment model participants helps to reduce the burden associated with model participation, that they aren't in this work alone, that they have a resource and a coach or some tools to be able to participate in this new model, because these value-based models really do require an investment of time and resources, whether it's around clinical and care management staff or health IT or analytics. And so not only having that technical support, but also upfront dollars to help to initiate the work more quickly can help to drive a faster results or potentially have a shorter runway to hitting initial goals for quality and cost savings. And in particular, for providers that serve vulnerable populations, having that technical and financial support to promote and encourage APM participation is key. I know in CPC Plus, the regional learning network was a very impactful part of primary care practices being able to participate, actively engage with patients in new ways that they may not have been able to do that without the support of the regional learning network. And I know that Primary Care First doesn't have that same level of technical support.
It does not have the same financial incentives. I know I had some conversations with CPC Plus clients who were looking for their next step, and it was hard to understand how to make Primary Care First work for many of them. But I think there is a future for value-based care for anybody who wants it, but I do think the support needs to be there. I agree. You had mentioned upfront investments. Of course, we had heard so much about the ACO track of the CHART model, the Community Health Access and Rural Transformation model earlier this year. And I know a lot of our clients were disappointed that piece of it was delayed for a year. We are waiting and seeing exactly what will happen with that upfront funding for rural providers. We're expecting that it will launch in 2023. It's possible maybe it will be expanded to cover other underserved populations or other underserved communities. We don't know, but we're certainly waiting those details. I'm wondering, so we're getting towards the end of the year, which is hard to believe, but I'm wondering what Caravan Health clients can look forward to in 2022, if there's specific areas that we're asking them to focus on or we think are promising areas for focus.
I'm most excited about some of our new disease-specific management programs. So we have some great resources in development in Caravan Coach and tools to use in the practice to support patients with COPD or CHF, to support patients with hypertension and chronic kidney disease, as well as diabetes. So our Caravan nurses are planning to lead small groups of clients through improvement initiatives called improvement sprints in each of these different chronic disease groups in 2022. And so we will use data to determine what programs will benefit which of our partners most, and start with these programs and partners first, and hope to be able to expand it across all of our clients based on their patient needs and sort of patient data, throughout the course of 2022.
Excellent. We always like to focus on the good news, and of course we have throughout this conversation, but I'm wondering if there are specific success stories from your client work that you can share with us.
Oh, Louise, I love this question. And given the great work that we do at Caravan and that my clinical leaders and improvement managers do every day with practices, I hear success stories every week. And I wanted to share one that came from our quality improvement workshop with clients just earlier this month. We had over 300 of our partners participating, and the topic was on better management of hypertension and diabetes to improve eCQM reporting. And in that workshop, as is our typical practice, we heard from clients who shared some of their experiences over the past few months. And so we heard from Riverwood Healthcare Center in Aitkin, Minnesota. Riverwood is a 25-bed critical access hospital with 3 clinics. And the data in Coach, as well as in their EHR, show that there were some big opportunities to improve the care they were providing to patients with high blood pressure. And so they started by looking at the patient panels for just 5 providers and identified 100 patients with uncontrolled blood pressure and no upcoming appointment. And with this list, they got their whole care team involved. They got the front desk staff who was given a script. They called each patient, telling the patient that their provider had requested that they schedule this visit to discuss blood pressure specifically. And they also shared some talking points on the importance of blood pressure and overall health. From that, 72 of 100 of those patients were scheduled. And when they came in for that visit, they met with a nurse practitioner and received education. They walked through a really neat decision support tool. And then their medications were adjusted. And all of these patients now have an action plan for hypertension, and 86% of them have reached optimal blood pressure control.
So I just want to stop you. 72 out of 100 were scheduled. That's an amazing outcome.
Yes.
That's really speaks to the power of the intervention. I mean, you can't argue with that. That really worked. Fantastic.
Mm-hmm. And having heard and seen the Riverwood experience and many other experiences and examples like this, we've identified and call out 4 different elements of success. And we use these across all of our client interactions and relationships. And the first one was the ability to use a patient cohort to identify a small targeted group to initiate care or new services so that it isn't overwhelming and it doesn't totally swamp your staff who are quite busy caring for all of the other sick patients that are in the office in a particular day. So using patient cohorts is one of those elements of success. A second is that these patients need frequent touch bases, whether in person with their provider or virtually with a care manager. And typically it's a combination of these approaches. So giving patients an opportunity to touch base and connect with their care team frequently. A third element of success is medication adjustments are very common and necessary. So setting up medication adjustment protocols within your organization based on literature and professional association recommendations. And then the fourth is establishing some type of same-day visit policy so that patients without a medical emergency can be seen quickly within your practice, and it avoids costly hospitalizations and setting up really a culture and an expectation for your patients to call us first. So those are the things that were certainly highlighted in the Riverwood example and that we talk to and train to across all of our partner sites.
Sure, best practices, if you will. Yeah.
Right.
Well, clearly can't argue with the results. So great work. Well, Nicole, it's been a pleasure having you on Healthcare by the Numbers. Are there any final thoughts or comments you want to leave with our audience?
You bet. Louise, I'm really grateful for the work of my entire team in supporting value-based care across the country, and really the dedication that they have put into supporting over 22,000 clinicians and their care teams. And I just probably don't get enough opportunities to recognize and appreciate their hard work.
It's great to be able to hear about it directly from you. So thank you for joining us today. For our audience, if you'd like to learn more about Nicole Banister and the work that she and her team do at Caravan, you can find her at www.caravanhealth.com and on LinkedIn at Nicole Banister. That's Banister. I want to thank everyone for listening today. We are Caravan Health, and this has been Healthcare by the Numbers. Until next time, take care.